Thank you very much. My name is Natalie, and I'm a third-year resident in Asuta Ashdod University Hospital. I would like to present the case of Mrs. E. She's a 77-year-old woman. She's also herself an internal medicine doctor. She suffers from morbid obesity with a BMI of 41, diabetes, and osteoarthritis. She went through an open cholecystectomy 20 years ago. She lives by herself. She has two very supportive daughters, and she performs basic daily functions on her own. Recently, following an upper GI bleed, she was diagnosed with stomach adenocarcinoma. This is her EGD. This is her tumor. It's right in the it's right in the fundus, which is it's very, very high on the stomach. The biopsy report was an invasive tubular adenocarcinoma with abundant necrosis, slightly elevated tumor markers. In order to perform staging and to plan her treatment, we perform a PET-CT and a staging laparoscopy with an intraoperative gastroscopy. So this is the PET-CT. Okay, you can see that the tumor is FDG avid. There's a small lesion in the right colon that she needs to look after, and she needs to perform a colonoscopy. And other than that, we didn't see any other metastasis. This is the So this is the staging laparoscopy. Okay, we can see that. This is Dr. Carmeli performing the gastroscopy while I'm holding the camera inside. We can see that the tumor, we will see it shortly, it's very high in the stomach. This is the pylorus. And also there was no visible metastasis or any visible spread inside the abdomen or on the liver. So in terms of her performance and health status, she's in her late 70s. She's not quite octogenarian, but just almost. She has a BMI of 41. She recently dropped 16 kilos with the help of Ozempic also. She has help around the house for 2 hours per day. She needs minor help with the activities of daily living. She's walking around on her own, needing, it's not a walking stick, it's basically a walker due to knee pain with an echo performance status of 1. She's anemic and she has almost normal albumin level. This is her walking. This is with her permission. This is the patient. Okay, we can see that she's walking quite well. Okay, she needs the help of a walker, but she can walk around on her own. She can't really go upstairs alone. So we sent her to a geriatric evaluation out of the hospital.
That's very important.
Yes, I just want to mention that the geriatric evaluation stated that she is fully cooperative and has appropriate affect and coherent speech and well-dressed, and she does not need any geriatric evaluation or assessment before surgery.
So just a comment? No, I think that one of the things in this day conference and what's going on elsewhere in the world is we are changing the language. We are changing the language of how we discuss among each other and about the patients. And here I think that surgeons, I'm a surgeon, needs to be taught how to talk differently about geriatric patients. But I think that also geriatricians need to be taught about how to talk about geriatric surgery patients. This is a very good example because it's not a hip fracture. Okay, it's not a hip fracture. I think it's just a little bit more severe than hip fracture, cancer of the stomach. So.
Yes, thank you. So yes, this is the paper we received from her geriatric physician in the HMO, which states that there's only a need of a geriatric evaluation prior to hip replacement surgeries. So the term rehabilitation is still yeah. Okay, just a sneak peek on some literature. It will be very short. This is a study, a multi-center study that was published in 2015 about the outcomes of gastric cancer in octogenarians. I know she's not exactly octogenarian yet. We can see here that although the mortality, the survival rate is lower in octogenarians, it's the yellow plot on the it's not the right side, it's the left side of the screen. But if we look at the disease-specific survival rate, it's quite the same. Okay, and although sorry, it's right here. And although the mortality rates drops every year in terms of major upper abdominal surgery for cancer, we can see also in stomach cancer, we still don't perform much more stomach cancer operations than we used to. So basically, the patient hasn't gone the operation yet. That's the key element here. Okay, she's due to first of all neoadjuvant therapy. Okay, this is basically it's a local regional disease, which means that she will. The plan, the oncologic plan is FLOT, is 4 courses of FLOT, which is a harsh therapy, okay, and then a total gastrectomy due to the high position of the tumor, and then another 4 courses of FLOT, which is it's a very harsh.
So the question is, the patient is not being operated. It shows you that everyone this is not full time. But our question is whether to go to full blown. She needs perioperative chemotherapy, or at least some kind of multi-modality therapy, not the single modality therapy, or the single modality. Maybe all full-blown multi-modality.
Okay, what do you expect by the multimodality treatment? If you see at the prospective trials with multimodality treatment, I would say 2 things. The increase of 5-year survival is few percent, less than 10, first of all. Secondly, all the prospective study excluded those patients. So we don't know if those patients will benefit of a preoperative chemotherapy. This is very important. Moreover, if you look carefully at the prospective study, you will see that but in younger patients, you have always a percentage of patients that don't reach the surgery because of the preoperative chemotherapy. So in a nearly 80 years old patient, be very careful. Moreover, it's depending of the surgeon. And I'm very strong with this sentence. If you have a good surgeon who is performing a good D2 lymphadenectomy with a gastrectomy, the differences, and we saw the papers from the Netherlands comparing neoadjuvant chemotherapy or perioperative chemotherapy with no perioperative chemotherapy in expert teams, no differences between the 2 cohort of patients. Only in multicentric prospective studies we showed that there is a difference because of the quality of the surgery and not because of the efficiency of the chemotherapy. So if we put all that together in this patient without any proof of improving the survival and the outcome, and if it's in the hands of an expert surgeon, I would say go to upfront surgery and not to multimodality treatment.
Dr. Carmelli, it's your decision, your call. You are the best surgeon.
Thank you. Well, I agree with you, first of all, but you know, on the FLOW trial, they did have this kind of patient as well. The 25% of the patients were over 70, and there was no limit of the age. But I do agree that we don't know exactly what is the benefit we get out of neoadjuvant treatment for these kind of patients. And obviously, it hasn't been checked, the FLOW or other regimens for neoadjuvant surgery and adjuvant treatment in comparison with only post-operative treatment. So this is something that we don't really know. And I think one of the worst things that happened in the last few years for an upper GI malignant patient is the encounter of the FLOW regimen, which is very bad, very difficult for them to underwent. And this is now the gold standard. So it's hard. And one of the questions I wanted to ask the audience is, should we, if we decide that she had a node-positive disease, and then it's easier to decide that she will benefit from neoadjuvant treatment. This is not the case with her, but if she would have a node-positive disease, would you choose another protocol? Would you choose other protocols for geriatric patients than from the general population of patients? What would you say?
This is a difficult question. Would you, Daniel?
The thing is, the feeling is with geriatric patients, the perioperative chemotherapy, it's very aggressive chemotherapy. I feel that it's very aggressive, and we see the patient coming to the surgery much more frail than they were before. And this is really questionable. And when we see the results of teams like in the Netherlands, with experts teams, no difference at all between the two cohorts of patients. It's remained questionable. Of course, I understand. University, hospital, academic hospital, prospective trials, we apply the results of the prospective trials. Of course. But medicine is sometimes a little bit different. And that's the reason why we have teams and we are building geriatric cancer centers and of geriatric surgical centers, and especially to try to select better the patient who should undergo multimodality treatment and the one who should not go. This patient is a little bit borderline, I would say, because I don't know the patient, but when we see the patient walking and not taking the stairs and more or less obese, I will be very, very careful for multimodality treatment when we know that this multimodality treatment with the chemotherapy that our colleagues oncologists give, it's very aggressive.
Short remark. If a patient is deemed frail or in need for rehabilitation, giving him chemotherapy before surgery is the opposite of that, is shooting ourselves in the foot. The added survival benefit after surgery by giving them chemotherapy before surgery is not relevant, because if we're talking about optimizing them to surgery, for the procedure itself, giving them chemotherapy is doing the opposite of that. So if the patient is frail, think about the added benefit of that is so far away. Let's go through surgery first, and that's the real test if the patient can go for more treatment after that.
So,
okay, so I'll just add that the patient, as I said, she's a doctor herself, and her two daughters are nurses, and they all want for an upfront surgery as a instinct in their, I think.
Next week. So I want to thank.
One short comment, and maybe not politically correct.
That's good.
We've said many times today patient goals and what the patient wants and so on. It's not so simple. It's very zeitgeist, you say. It's the spirit of the time. Of course, what the patient wants. I'm not sure that the patient can really evaluate. Of course, you have to understand his goals. If the patient, you tell him, I can elongate your life by 8 months at the cost of colostomy, and he say, I don't want, it's a very good, reasonable decision. But sometimes to evaluate, to send the patient 8 years old to read the literature that we don't know to interpret, I think, and maybe we will read it. I think we're maybe going too far on that. Maybe we need some more guidance. Someone say we can push the patient wherever we want. We don't need to push him, but we definitely have to give him a more solid advice.
I think that at the end of this presentation, you actually showed us how decision is being taken in geriatric medicine by the family and the patient. I don't speak about clear-cut patients, 90 years old demented, fully dependent patients. Of course, no one will touch him, but we are speaking about the borderline patients. So we are just advisors. I don't get the decision. I just give them the information, the data. They go home, speak with the family members, and come back to me with the decision.
I think another thing that we need to address, and another thing that we can build here, is a multidisciplinary decision team or multidisciplinary discussion team, surgeons, geriatricians, anesthesiologists, ICU, rehabilitation, all the teams that sitting here. Each hospital should establish a team for the highly frail patients, for the major surgeries, or even severely frail patients for the moderate surgeries. And I think one of the problems is that it's not existed yet, and some of the patients are, yes.
One thing which I grapple with sometimes is that we've gone from an era of very paternalistic medicine where we told the patient whatever we called the shots and they must do whatever we say. And it's now gone the other way, that we put all the eggs almost in the patient's basket and say, here's all the information, take it and go home and decide. And I think part of our responsibility is really to guide the patient, share the information, but take some responsibility ourselves for the decision making.
Very good comment.